Hi everyone, this is our video exercise and it was made by me, Andressa Maeda, and my partner, Mariana Beadle. We are going to talk about a group of drugs called proton pump inhibitors or PPIs. Some examples of this type of drug are lansoprazole, esomeprazole, pantoprazole, and omeprazole. We choose omeprazole to specify their mechanism of action, their excretion, the interaction of this drug with other drugs, and their side effects as well. These drugs can be used in the treatment of many conditions, such as dyspepsy, peptic ulcer disease, gastroesophageal reflux disease, eosinophilic esophagitis, stress gastric prevention, and gastrinomas or other conditions that can cause hypersecretion of acid.
So, to understand the mechanism of action of the omeprazole, we need to understand the physiology first. When the parietal cell is not activated, the pump is located in an impermeable vesicle in the cytoplasm. Once we activate the cell by a stimulus such as gastrin, histamine, or acetylcholine, the proton pump goes to the plasma membrane of the secretory canaculus of the cell, and there it will help the permeability to potassium increase, so protons can leave the cell and potassium can go inside using ATP energy. So that will make the pH of the stomach lemon acid. Omeprazole will be absorbed in the intestine and it will reach the parietal cells through the bloodstream. When the pH is around 7, omeprazole can cross the membrane until it reaches the secretory canaculus of these parietal cells, where the pH is going to be around 2. And because the pH is acid, omeprazole will be converted into its active form known as sulfonamide. And sulfonamide will be trapped in the alpha subunit of the pump, which is the functional part of the pump. And that will inhibit irreversibly the activity of the enzyme. And the result of that is because the enzyme is inhibited, there will be no longer protons being pumped into the lumen of the stomach, and that will increase the pH.
The majority of the dose, about 80%, is eliminated in urine as at least 6 metabolites. The remainder of the dose, about 20%, is recoverable in feces, which implies a significant biliary excretion of the metabolites of omeprazole. Because the use of omeprazole is extensively metabolized by the hepatic cytochrome P450 system, interactions with other drugs may occur, such as methotrexate, warfarin, diazepam, phenytoin, antipyrin, and aminopyrin. Some drugs need an acid environment to be well absorbed. However, omeprazole increases the gastric pH, making the stomach environment less acid, and by that, drugs like atazavanir, antifungals, iron salts, and erlotinib can be poorly absorbed when are taken together with omeprazole. The use of omeprazole is presumably related to the inhibition of gastric acid secretion. It comes with a fall of pepsinogen levels and with an increase in gastric pH. These bigger levels of gastric pH can cause two main consequences. The first of them is the hypergastrinemi, which is the excess of gastrin in the blood, and the second one is the decreased absorption of calcium, magnesium, and vitamin B12. It's good to remember that this decrease in absorption is caused by the chronic use of proton pump inhibitors. The adverse effects with the use of omeprazole are not frequent, but when they happen, they are generally of light intensity, can disappear with the continuation of the treatment or after the treatment suspension. May occur vomiting, nausea, headache, transitory diarrhea, flatulence, and dizziness.
And that's all, folks.